Hello, this is Dr. Jorge Sanchez. I am going to talk about hypertension today and just an overall review, base it on treatment-based and see how if we can improve our clinical skills. So let's go ahead and get started. So today I'm going to talk about the criteria for hypertension, specifically the goals, a little bit about complications, as well as the treatment of hypertension. So the first thing is, before we consider using medications, it's important to focus on non-pharmacological treatments. And so weight loss, that is a very important goal. So most, I would say, causes of hypertension is due to obesity. So if they can lose their weight, then their blood pressure improves. Reducing salt intake, and that's a big topic, and I'll produce another video discussing this. There's a lot of sodium that is lingering in foods, and patients can unknowingly consume sodium, and that can cause high blood pressure. So now also exercise, that is very important, and limiting the amount of alcohol intake can actually reduce hypertension. So let's talk about the JNC8s. So now, this is very much age-based, and so the big delineator will be the age of 60. And so those that are older than 60, there's evidence to show that having a goal of 150/90, I use this a lot as far as when to initiate treatment, rather than getting them to, and also adjusting medications. So I would say that if there's a consistent blood pressure, and I use generally about 6 measurements at home, if they bring in their log and shows a blood pressure consistently around 150/90, that's typically a time when I start initiating medications, and I try to adjust medications to try to get them about 150/90. Now, younger patients is a little more strict, so 140/90. So the diastolic is the same, but the systolic is a little more strict. Now, if there is a disease that is of higher mortality than age, meaning that if the disease is of significant cause of mortality, then it's important to actually be a little more strict with your blood pressure, regardless of age. And so, so if somebody has chronic kidney disease, then regardless of if they're below or above 60, they will need to have a blood pressure goal of 140/90. Now, the less than 70, the reason why there's an age thing is because it's harder to define what chronic kidney disease above the age of 70. There's not as much research out there. And so, but what I generally do is I still assume the goal of 140/90 if they have chronic kidney disease. Proteinuria is another one of those conditions that will kind of trump age, and so regardless of age, if they have proteinuria, then 140/90 tends to be the goal. And then also if they have diabetes, again, so that is also a disease modifying factor, and so will actually cause the goal to be about 140/90, even if they are older than 60 years old. There are no randomized controlled trials showing if there's 140 versus 150, if there's a difference, and so we generally shoot for 140/90. Now, this chart is basically saying that although the goals are 140/90 or 150/90, the risk of strokes actually increases at a lower blood pressure. Even at pre-hypertensive ranges, you can actually have a rise of blood pressure. And so there's not like a J shape to the curve. It's actually quite linear. And so so we know that anything above 120 or 115 over 65 can actually increase the risk of stroke. It's just that medications are only indicated at a goal of 140/90 less than 60 years of age, or 150/90 older than 60 years of age. So now the JNC8 was published prior to a few trials. So the SPRINT trial came after the JNC8, and that has contributed to a lot of confusion. So we'll go over the SPRINT trial. So the whole goal of the SPRINT trial is to determine whether treating blood pressure to a target systolic blood pressure of less than 120 is superior to treating to the commonly recommended target of less than 140. So what they did is they chose a population of about 9,000 patients that were inclusion criteria was they had to be older than 50 and blood pressure systolic between 130 to 180 and also an increased risk of cardiovascular disease. But the big thing is they excluded patients with diabetes and those with prior stroke. And so in my general population, which I treat a large Hispanic population, I have quite a few patients who are hypertensive and diabetic, and so I am not able to apply this type of research to that population. So now as far as what's considered high risk, and so those who were included in the study, they defined high risk as those older than 75. That counts as a high risk patient, documented coronary artery disease, peripheral vascular disease, or cerebrovascular disease, except for stroke again. So if they've had a stroke prior in the past, then you cannot apply the studies to them. Elevated coronary artery calcification scores by CT, I will say that is rather not helpful. It's not practical. I don't use the calcification score very often. So left ventricular hypertrophy was included as a high risk score, as well as ABI less than 0.9. GFR of 20 to 59, or a 10-year Framingham risk score of greater than or equal to 15%. So this was a double-blinded study. They're randomly assigned to either systolic blood pressure of 120 or a blood pressure of 140. And the key factor there is that this was automated blood pressure measurements, and so one of the things about research studies is that you cannot apply this data to patients who check their blood pressures by manual blood pressure measurements, and so you have to keep that in mind. So, and the primary outcomes was myocardial infarction, other acute coronary syndrome, stroke, heart failure, hospitalizations, or a death from CV causes. And so this was a composite of all those. And so I like to think of the SPRINT trial as the high-risk patients without diabetes. And so this is the results in the primary outcome on the intensive treatment group. There was about 5.2% of the patients had developed the primary outcome of an adverse event, but percent per year was 1.65 for the intensive group. Now for the standard group, it was a bit higher, so the adverse event was about 6.8 for the whole population, about 2.1% per year. And so if you look at the hazard ratio, now again, hazard ratio is like a type of relative risk, but on a more on a time to event type of scale. So it's in essence, practically speaking, is the same as the relative risk. And so the relative risk was actually less in the intensive group by 0.75. It did not cross the 1 value, and if you look at the p-value, was less than 0.001, and so it was statistically significant. And so the SPRINT trial summary was that for 70-year-olds at risk of MI, CVA, and without prior diabetes or stroke, then consider a goal blood pressure of 120. And so that is actually different than what the GNC8 had discussed. Now, keep in mind, it needs to be automated blood pressure measurements. But the way that they check their blood pressure is quite different than in clinical practice. And so it had to be in a quiet room without a physician in the room and measured 3 consecutive times. And so if you're going to apply this evidence, it's important to know that the measurements they used were very different than clinical practice. So again, this is in conflict for JNC8, whose blood pressure would be 150/90 for those that are over 60. And also interestingly, the patients with chronic kidney disease were included as a high risk. And if they were, so normally that would be 140/90, but apparently here they're talking about 120 as a goal. So let's go on to the ACCORD blood pressure trial. And so the purpose of this was to actually look at diabetic patients, whereas the SPRINT trial excluded them. So in patients with type 2 diabetes at high risk for CV events, does intensive blood pressure treatment of the goal of 120 reduced rates of non-fatal MI, non-fatal stroke, or CV mortality when compared to standard treatment with blood pressure less than 140. So they looked at about 4,700 patients with type 2 diabetes who had cardiovascular disease or at least 2 additional risk factors for CV disease. So these were high-risk patients. Excluded were those who had a BMI of greater than 45, if they had a serum creatinine of more than 1.5, so patients with chronic kidney disease were excluded, and other serious illnesses which were not defined. So I would say that I would be able to apply this information to my diabetic patients, excluding chronic kidney disease and my obese patients. So they were randomly assigned to a group of blood pressure 120 or to 140. Blood pressure was measured manually, so which is different than the sprint trial. And the primary composite was non-fatal MI and non-fatal stroke and death from CV disease. So now here are the primary outcomes. It showed that intensive therapy showed a 1.87% per year rate, whereas the standard therapy had 2.09. And if you look at the hazard ratio, it does cross the 1 value, and the p-value is actually greater than 0.05. And so this shows that this is not statistically significant. And so not only do you have no difference between the two groups, but if you look, you actually have significant side effects. And so if you look at with the p-values that are less than 0.05, so hypotension, syncope, and as well as bradycardia, arrhythmia, and hyperkalemia were significant. And if you go down lower, you'll see that adverse laboratory measurements such as potassium disorders, elevated creatinine shows to be a side effect, and you see it as well as the clinical measures as well. So what does it say? So in those that are 60-year-old patients, now keep in mind that the mean age for the core trial was actually 60, and they included those with diabetes and higher risk of coronary disease. There apparently is no difference between 120 and 140. And so it did include diabetics in the study. It makes a difference between the core trial and the sprint trial. So I wonder if that was the main, I guess, overwhelming diluting factor to the effect size. Might have been the fact that diabetic patients were included. But if you exclude those patients, then there apparently is a clinical difference. And so in the JNC8, there isn't a trial to delineate between 140 versus 150. So here's a side-by-side comparison of JNC8. And so we have older patients, 150 over 90, younger patients that are 140 over 90. Unless they have chronic kidney disease, there's stronger evidence, of course, for those that are less than 70, so a goal of 140 over 90. Proteinuria, again, is a disease-modifying factor, so 140 over 90. And then diabetes is 140 over 90. But if you look at the sprint trial, so the mean age was about 70, and those are at risk but did not have prior stroke or diabetes. Apparently in that group, 120, an automated blood pressure measurement is probably the goal. And then the core trial is the mean age was 60, but they include diabetics, and so there's no difference between 120 versus 140. So only the difference was that there's added side effects. And so the goal is going to end up being 140, which is actually in agreement with the JNC8. But keep in mind that was a manual blood pressure measurement. So I would say that the non-diabetic older patients can probably have a little lower blood pressure goal of 120, but the diabetic patient falls in line with the JNC8. So here's a little bit of graph showing of JNC8s, and so here you got to keep in mind though that it's patients that are older than 18. You want to implement lifestyle modifications, and so if you look at the patients, you got to first decide whether they are diabetic or if they have chronic kidney disease. Now, if you look at patients who do not have the diseases, then those older than 60 whose blood pressure should be about a goal of 150 over 90, and if they're younger, 140 over 90. The only exception, again, is if patients are older and do not have diabetes but are at high risk of having coronary disease or some event like that, then you might want to maybe consider a blood pressure goal of 120 as a systolic. Now, the other thing is looking at ethnicity. Now, ethnicity is not, it does not modify the goal, but it does modify the types of medications you may consider. So in non-black patients, I mean, basically you can just pick whatever medication that you want to use. Thiazides, ACE inhibitors, ARBs, and calcium channel blockers are all effective. But in black patients, you do want to consider using either thiazides or calcium channel blockers. So now, if they do have diabetes or chronic kidney disease, just remember that that does change the goal of 140 to 190. And it's not included in this chart, but proteinuria as well. It does change the goal to 140 over 90, regardless of age. And for that population, for those who have chronic kidney disease, it's most likely that ACE inhibitors and ARBs or ARBs will be effective. So again, black patients, thiazides and calcium channel blockers, consider long-acting medications for calcium channel blockers. In black patients, really, you can use any medication on that list there. Chronic kidney disease, you want to consider ACE inhibitors or ARBs. Again, if they have proteinuria, then ACE inhibitors or ARBs. Non-dihydropyridines, calcium channel blockers, is a second-line drug, as well as aldosterone inhibitors that will be considered a third-line drug for those who have proteinuria. And now, congestive heart failure patients would benefit from beta blockers and ACE inhibitors, spironolactone only if they have severe heart failure. Now, this is actually a pretty important slide. There's not a whole lot of information, but I find that there are many patients, some patients that are new to me that come in from seeing some other physician. They have hypertension uncontrolled. They have no other indication to be on a beta blocker, and yet they're using beta blockers solely to control hypertension. So actually, beta blockers are very poor medications in regards to controlling blood pressure. And in fact, it's considered a fourth-line drug if they're not controlled on either a thiazide, calcium channel blocker, or ACE inhibitor. And so the only reason to consider putting somebody in beta blocker is if you need it for migraine prophylaxis, if they have atrial fibrillation, if they had a prior MI, or if they have stable coronary disease that's symptomatic. And so, but other than that, there's not a whole lot of reason to use beta blockers. Alpha blockers also are considered maybe fourth or fifth line, so they should not be used initially. So generally what I do, I use thiazides, calcium channel blockers, and ACE inhibitors. And if they are on all three medications and still uncontrolled, generally what I do is I refer to my nephrologist. So now the question is, when does actually start off on two medications straight out of the gates? And so that's so patients with new diagnosis of hypertension, if they have if they are 20/10 above goal, then that's actually when it's a good idea to start two blood pressure medications at the same time. Now, traditionally, it's going to be a thiazide and an ACE inhibitor, but the ACCOMPLISH trial actually questioned this, and so they took two groups. One group had benzopril plus hydrochlorothiazide, and versus benzopril plus amlodipine, the second group. And although there was better with the hydrochlorothiazide group, there was better blood pressure control. Actually, they had worse cardiovascular events, which is kind of flies in the face of what we think about hypertension. So even though their numbers may be slightly worse, their primary outcomes are actually with cardiovascular disease are actually better. So when you look at patient-oriented goals, really, I think that the best thing to do is to consider benzopril plus amlodipine. And so now, if the goal is just to change the number, then sure, benzopril plus hydrochlorothiazide is the way to go. But if I'm a patient and I have high blood pressure, and I'm going to probably say, hey, give me the benzopril plus amlodipine, again, only if my blood pressure is 20/10 above goal. So a little bit about thiazides. Now, thiazides were considered as first-line medications, all based from the ALLHAT trial. But the caveat is that they use chlorthalidone and not hydrochlorothiazide in the ALLHAT trial. And so it did, they had lower rates of heart failure and cardiovascular disease, so that was true. Better blood pressure control. But when it came to primary outcome of fatal MI, fatal coronary heart disease or non-fatal MI, there actually was no difference. And so what this says to me is that there apparently you have less morbidity, but you don't have any difference in mortality when it came to chlorthalidone. But the problem is that we oftentimes try to infer research into try to assume that hydrochlorothiazide acts the same, and in fact, we think that it may not be the case. There's actually little evidence that hydrochlorothiazide can be used as a substitute for chlorthalidone. And so if I have a patient who I'm thinking about using a thiazide on, particularly an African American patient who's uncontrolled, I might want to consider switching their hydrochlorothiazide out for chlorthalidone. So chlorthalidone may be better to control blood pressure than hydrochlorothiazide, but you have to be careful because there's a lot more hypokalemia associated with chlorthalidone, so you'll have to check your labs a little more frequently. So hypokalemia, glucose intolerance, and hyperuricemia are all effects from thiazides. Now, if you have a low salt diet, it does help reduce the risk of hypokalemia. And they should be on a low sodium diet anyway, but actually it heightens the point that if they're going to be on chlorthalidone, they really need to be on a low sodium diet. So follow-up management, if blood pressure is not to goal within 1 month, then consider these options: increasing the dose of the initial drug. You may consider adding a second drug, but generally what I try to do is that I try to maximize what medicines they are on before I consider adding a second drug. So in conclusion, really focus on diet and exercise, and I'll talk more about that in a future video. Know your blood pressure goals. It's very important. Diseases will modify what the goals are, and then ethnicity will modify what type of medications to use. Know when to start 2 medications. Generally, it's going to be 20/10 above goal. And again, just look at the controversy between calcium channel blockers plus ACE inhibitors versus hydrochlorothiazide plus ACE inhibitors. So blood pressure is actually a measurable outcome amongst many physicians, and so we feel the pressure to reduce the number regardless of what patients actually care about, which is going to be reduction of mortality. So, but apparently calcium channel blockers plus ACE inhibitors might actually be better for patient-oriented outcomes. And know how to adjust the medications. That's very important. So I hope this video has been helpful to you, and hope you have a great afternoon.